Good afternoon, and I thank the organizers for giving me an opportunity to present a completely different problem that we have. It actually started with good intentions, like the Chinese say, the road to hell is paved with good intentions. So the idea started with the government and the entire healthcare community working towards a specific statistic called as the infant mortality rate, or reducing the infant mortality rate. And the government set up a large number of what are called as neonatal intensive care units to take care of premature babies so that they could survive in district hospitals, and possibly at sick neonatal care units at community hospitals. And a lot of private players also set up, medical colleges for example set up NICUs. One of the things that did come up, which was relevant to our area of expertise, which is ophthalmology, was that a lot of these babies also suffered from specific disease called retinopathy of prematurity. This is a potentially blinding disease. It has a very specific disease course. I am not the medical person to talk about it. Krishna would be taking these questions later. It's the fifth leading cause of bilateral childhood blindness in the world. The big challenge, it occurs in premature babies. There's a whole scientific understanding of why this occurs. It especially appears in low birth weight infants. It actually happens due to abnormal proliferation of blood vessels in the retina. The entire course of the disease goes through between the third and fourth week of life, and the babies need to be screened within the first month of life. Now look at the other side of the scenario. These babies are in a hospital, they're possibly in an NICU. Maybe the pediatrician knows what needs to be done. He doesn't have the skills to do it. There may or may not be an ophthalmologist available at that NICU. Now, how do you marry these skills that are available, the intent to survive for the baby, and to give a healthy life to that child? Now, all these three things need to come together. It's got a very, very good prognosis. When you treat it, screen and treat it, the baby's vision can be saved. The challenge was, many of these babies are there. You would be surprised, a single medical college in a town like Shimoga would have about 40 admitted NICU babies at any given point of time. That's a large number. And this happens in many district hospitals. So, not trained ophthalmologists to screen these babies because they're very, very small infants. I will show you a little clipping of a video to show you how difficult this exam is. And babies are not being screened. In many countries like the US and possibly in the UK, it's mandatory that a screening be done. There's a treatment protocol that the ROP screening be done for babies of a certain age, of a certain weight. It's not there, like Dr. Shantu was saying, there's no protocol. There are no standards to follow. So what was done, we set up a ROP clinic in the State Referral Center for Pediatrics, which is the Indira Gandhi Center for Child Health. We set up a system by which a mobile camera travels around in a small car, goes to these NICUs. We use one part of telemedicine, which is telediagnosis. We diagnose it by uploading these photos. We also get a lot of the data from the neonatal unit, things like oxygen supplementation, the kind of feed that it's got, any other systemic diseases that it's got. It's all loaded onto a secure website. An ophthalmologist sitting in Bangalore, where the skills are rare. I think some kind of numbers can be shared later, is that there is a treatment and follow-up plan is decided by the ophthalmologist here, communicated through this very same website or by mobile phone where web access is not available. And treatment, the most important thing that we do is treatment is delivered in situ. How do we do this? We piggyback on the previous project where we have trained a lot of people, and there are trained vitreoretinal surgeons in many of these places. We provide them with equipment. I have a fancy name for it. We call it the Cinderella effect. For a day we make her the princess. That ophthalmologist gets all the equipment and he treats the baby there. The baby also has other challenges because the baby cannot be moved. It's in a very delicate state. It cannot be moved to a bigger center. The treatment will be delivered inside the NICU in a sterile condition. This is what we do. these are some statistics. It serves about 6 districts in Karnataka right now. We serve about 13 NICUs, including government NICUs. About 6,000 screenings have been done so far with the same thing. There is a nominal fee charged to parents of babies who can afford to pay. Babies who cannot, parents who cannot afford to pay for this are treated for free. The treating ophthalmologist is always compensated, either by the parents or by the institution through some donations. There is, we have recently published a comparison profile in the British Journal of Ophthalmology. I have some copies of the article. We have just come out with some statistical basis that shows that there is not much of difference between rural babies and urban babies. The incidence is almost the same. The problem is almost the same. I thank you once again. That was a brief introduction. I'll just leave you with a very short video that shows you how this thing works. This particular baby was about 1,400 grams. So that's the thing. Can I invite Dr. Srinivas and Krishna will be available to take questions.
Thank you very much. So, are there any questions on any of the last 3 sessions here? I have an interesting question. The affordability and the financial models. How did those just evolve in the course of putting your work together, in particular, for both sets?
Yes, we did work together on both sets. Krishna, you would like to take it?
Actually, we started with first providing care. Affordability was not the initial goal. It was more because our aim is we are an NGO, which is charitable trust. So we started with first addressing the problem of providing care, and we found that it was affordable, which was a very pleasant surprise because the at least cash flow sustainable. I would say. I wouldn't say that it will recover your capex, but your running costs are covered. You end up with a small profit if you're looking only at the running costs, but that does not take your capital into account. So that way, with one set of equipment, we've been able to push it for about 8 years, which was a welcome.
If I can just add to that, it costs about 800 rupees to deliver a laser photocoagulation session right now. This is in spite, it started off with about 600 rupees when we started in 2005. This is still accounting for all your fuel inflation and salaries and increased equipment repairs and things like that. Fortunately, what saved us is that the set of equipment that we chose, one of the first things that we told the funding agency was that no compromises on the kind of equipment that we're going to buy. If I'm going to put it up in my tertiary care center here, that's the same equipment that's going to go on the van, not something that could be bought cheaper. And that's been a good choice because it's served 500,000 kilometers of all kinds of roads. And these things, remember something, these things get disassembled and assembled every single day. So there have been about 6,000 odd assemblies and disassemblies because they can't be transported whole. That's contributed to the sustainability. The second sustainability thing is we share the money with the local doctor. There are many doctors who make up to 12,000 rupees in a single day with their share of the money, and that's significant. Even if you're an ophthalmologist, if you're, to just give you a comparison, if you made 1,000 rupee margin on a cataract surgery, you'll have to perform 12 of those to get that kind of money. And you have 35 satisfied patients who are coming back to you again and again. And, they also set up treatment networks. One of the projects that we did not present was we went into primary diabetes care after this, even though we are an ophthalmology hospital. The economic model works. It's possible to bring down costs and still deliver.
I'm just interested also in the economics. I've seen in a lot of projects based in rural India that you have a sort of cross-subsidy model where or subsidised model where you assess a patient's ability to pay. How does that work in practice? How do you prevent exploitation of that system, and do those subsidised costs, do they cover all the running costs, or do you have external funding to help run programs?
To take your first question first, we actually, you're right, it's very difficult to judge who's capable, who's incapable of paying. We usually give that judgment to the local ophthalmologist who's seen his patients coming back to him again and again. There is a reason why he does not want to provide subsidy to a patient who can afford, because he gets a share of the revenue. One. Number two, in spite of all that, there will be a certain amount of exploitation. But I would say that's in a larger sense, if you look at it, if you're going to be more inclusive than trying to exclude a patient who couldn't afford treatment if he's gone out of the treatment net, that's more painful than a fellow who's tweaked a few pennies off you. But I would say, yes, it is a problem. We leave it to the best judgment of the local ophthalmologist, because we are foreigners. We don't even know what the local conditions are sometimes. And more or less, in spite of all the subsidies, the running costs are taken care of because of the numbers.
See, now, typical tertiary care center, you would do about 10-12 treatments. Medium to large tertiary care center. I'm talking about actual laser photocoagulations that you deliver. You might see about 150 patients in a day, but this one does about 30. So it's doing a large amount of work, and it's not just doing lasers. It's doing field tests. It's doing fundus angiograms. It's doing biomicroscopy, all kinds of stuff. So it's in effect doing a large number of treatment and diagnostic tests at a lower cost. To give you some kind of numbers, about 35% of patients pay, and that's enough to not just run the project but also to make profits, and the local doctors are happy. What actually happens is that the fellow who gets free treatment for diabetic retinopathy or diagnosis over 5 or 6 sessions will come back to you for a cataract, or will come back to you for something else, or will come back to you for a pair of glasses. It's patient retention. One thing that's kind of dirty in the medical world is there is a cost to acquisition of the patient, which there is, whether it's by referral or by whatever means you want to call it. There's a cost of acquisition, and this cost, the local ophthalmologists are willing to pay that kind of cost by treating the poor patients. It's possible to do it.
Okay.
So what happened?
Was ISRO part of your Nayana project?
Yes.
Yeah, it
ISRO
was.
did provide the satellite connection. So initially we started off with tele consultations as well. Because
That's the dish you see on the van.
after we handhold the patients, handhold the doctors, they start treating on their own, but they still have some doubts when they need second opinions. We used to use the satellite connection, but of course now we don't use the satellite connection much because of internet and
Much faster.
Much faster.
If I might just ask one observation, I think there's a really interesting theme here about the way equipment and context and economics interact. When you've taken equipment that's never designed for doing what you're doing with it, I imagine the original equipment manufacturers are horrified at the number of times you've assembled and disassembled your equipment. But not only will they not guarantee it, but so you've had to modify hugely original equipment to make it fit circumstances, and that theme of how the technology fits with the process, fits with the organisation, is something I see coming out in this time and time again. And that's the complexity of the system.
Thank you. One other thing is that the equipment manufacturers also benefited largely from it. One thing that Krishna did not say was that it's now replicated in 9 countries around the world. There are about 16 vans like this running in Thailand. There are 2 vans running in Bangladesh that we know of. There are 5 other projects like this in India that we support through technical expertise and things like we don't participate economically with them. But it's gone. I've even heard that somebody has taken this, I'm not personally sure of this, but somebody has taken it to West Virginia because similar problems. Doctors are in big centers, there is a large rural population, there's no screening, and I don't know whether they're doing treatments because of the legal issues.
I guess I was wondering, since there's a much larger number of healthcare organizations doing these kind of mobile things now, can you get the manufacturers to basically give the manufacturers enough of an incentive to help just modify the instruments so that they're easier to assemble and disassemble in a hurry, or have they just been leaving not changing them at all so far? Like not decreasing the quality, just making assembly and disassembly easier.
Actually, they've always been. If you talk to somebody like Sai, on an average, a laser travels to about 50 conferences in a year, all over the world. So in India itself, there are about 20 ophthalmic societies to which it goes, to different exhibitions. They're already doing it. They just don't want you to do it. That's an issue. That's like you take a typical hospital which has a laser photoprojector. It sits in the outpatient. It also travels to the operating theatre for endo lasers. That's a typical usage. So it's already made for. Many of them are very modular. It's easy for them to repair. It's easy for them to train. All these things are already there. It's like, for example, they were not willing to sell us the side tubes for observation for laser slit lamps. We said this is already there. There's a beam splitter. You are willing to sell me a camera along with it, but you're not willing to sell me a side tube. So we disassembled a side tube from a microscope and stuck it on. It works on the same. It works on the same beam splitter because he's not going to create one more part just to do anything. I guess you'll have to a little bit arm twist. It works.
Thank you.
Thank you very much.
Thank you, sir.
Thank you.